We'll move forward with the next speaker, who doesn't really need an introduction, our Professor Dr. Adeyi, Professor of Pathology at the University of Minnesota. And he will talk to us about other cancer syndromes beyond FAP and Lynch. Thank you, Adeyi.
Thank you. Okay, I know I confused everybody in the morning when I said that Dr. Montgomery will be speaking before me. But it looks like she hasn't heard my voice for a long time, so she decided to call the airline and make sure they mess up her flights. And now she's stuck in Minneapolis till tomorrow. And I was trying to warn her yesterday that she shouldn't tell us when she's going, that we tell her when she's going. So I get to speak now. But so I just want to remind us of some of the other things that exist outside of the Lynch and the FAP. So most of the time, we as pathologists, we get biopsies. And especially when we are dealing with colorectal carcinoma, there are some testings that are reflex. So I just want to go through some of these other syndromes that we as pathologists, we have a role in sometimes being the first people to flag some of these syndromes. But the important thing is for us to understand when our diagnosis is going to trigger something down the line. So that's the purpose of this. So I don't have anything to disclose right now, because it's just always easy to say no disclosure. So this is what I want to go through about, just to highlight some of the newer entities that are also coming on board that some of us may not be aware of today. And then just to mention as I go along some of the pathologist roles in this. So most of the syndromic polyps of the GI tract, the first thing is to remember that almost all of them are autosomal dominantly inherited. And these are the exceptions: DNA-based repair and the non-Lynch. Now, there's a lot of candidates in that category that I hope to cover in the next 10 to 20 minutes. And also know that when we talk of FAP, it comes in different sizes and shapes. So there are so many variants of the FAP syndrome right now. So the GAP syndrome, the Troco syndrome, that Dr. Luquet mentioned and said something about this morning, Gardner syndrome, and my favorite tumor in the Gardner syndrome is the desmoid, because again, we encounter that in patients with FAP syndrome. And then there are all the other attenuated form. The Muir-Torre syndrome, which may be associated with all the same tumors that you see in the Lynch syndrome. So endometrial, bladder, breast, and a few of the other tumors that you see in Lynch syndrome. But in addition to that, you can get some sebaceous neoplasms and sebaceous hyperplasias, some cutaneous proliferation keratoacanthomas. So most of these are commonly associated with the MSH2 mutation. And we can see MSH2 also in Lynch with colonic tumor, but that is quite uncommon. So we tend to see the MLH1, PMS2, and MSH6. So there are other tumors that also been reported in relation to Muir-Torre syndrome, the hepatocellular carcinoma. Now, the Troco syndrome, like I said, could be associated with the Lynch profile, in which case the other tumors, especially the brain tumors in this case, will be GBM, glioblastoma multiforme, with some other gliomas and some other hematologic malignancies. There's another variant of the Troco syndrome that's actually related with the APC gene. And also there's a defining brain tumor there, but it's more likely to be a medulloblastoma in those cases. So that's all I'm going to say about the FAP and the Lynch, just to give the flavor of some of the other syndromes that are related either as first or second cousins. So now let's go on to the other syndromes. So the first case I'm presenting is a 44-year-old man with a history of hereditary hemorrhagic telangiectasia. And so this man was found to have multiple gastric and colonic polyps. So after undergoing a series of biopsies, eventually they decided to do a gastrectomy. So this is one of the sections of the gastrectomy material. And here you see that the stomach is just loaded with a whole lot of these bumps. And as you look at the bumps, you see a polyp that we've seen something like this earlier today. Actually, I think we've seen it with Dr. Montgomery and Dr. Luque's presentation. So you see the polypoid lesion with some edema in the stroma, some dilated and ectatic glands or crypt there. And again, this is a patient that's already had some prior colonic polyps before he got this gastrectomy. And here you see something very similar, edematous stroma, dilated glands and crypt there. So this takes me to the group of the hematomatous polyposis syndromes. And so the first one that we are talking about, which is what I just showed you, is that of juvenile polyposis syndrome. And remember, this patient first had a history of hereditary hemorrhagic telangiectasia. So we need to remember that the same gene that is mutated in a germline in patients with HHT is also one of the genes that have been reported to be mutated in patients with juvenile polyposis cona. So that history itself, will have been something to prompt you to start thinking of what could be the correlates of HHT in a patient with multiple polyps. Now, there are other genes that are associated with the JPS, BMPR1, which again, we had something about that this morning. One of the genes that some of us may not have heard about is the TGF-beta dysregulation due to mutations, also germline. Now, if you look at all those three genes, they actually all operate within the same biologic process. So it's not surprising that three different genes could give you the same or identical phenotype. So patients with juvenile polyposis syndrome, they may be found to have mutation in one of those. And it looks like the ones that tends to affect the stomach more, it's possible that they may be the ones with the TGF-beta mutation. Now, what's the importance of this? As pathologists, when you get series of biopsies, colonic and everything, and you're about to make the diagnosis of juvenile polyps, you get to a certain number, there are 3 of them, you need to know that sometimes the moment you hit that button, it might trigger a series of reactions, even if we didn't say it, because in the endoscopist mind, they are counting the numbers and they see some certain numbers, they start thinking of some of these syndromes. Another implication of that is to be very sure that what we are calling juvenile polyp is actually a juvenile polyp. And as we saw this morning, a juvenile polyp can actually look like a Peutz-Jeghers polyp. And I'm going to show you some of the examples, especially when you are in the stomach. So once you establish this diagnosis, it's likely that you're going to be receiving a biopsy in those patients at least every year. So this is one picture of a patient with juvenile polyps. And one of the things which again was mentioned or alluded to this morning is the usually smooth surface of that polyp, which the endoscopics also tends to appreciate grossly. Now, some of this might be quite many. Of course, nowhere as many as you get in patients with APC syndrome, where you can get 100 of these polyps. So the diagnostic criteria in these cases are presence of 5 or more juvenile polyps in the colon, or presence of juvenile polyps throughout the GI tract, including the stomach, or any number of juvenile polyps in a patient with a positive family history. So this is the endoscopic thing. So it tends to be pedunculated most of the time, and the surface is quite smooth. So this is another example of the same process that I'm showing you again. So just look at the edematous stroma, the dilated crypt. Sometimes the surface is ulcerated, like we saw this morning, and you can see a lot of granulation tissue in that patient. In adults, the closest appearing polyp that is often mistaken for a juvenile polyp is that of inflammatory polyp. So sometimes it's actually impossible for you to differentiate between the inflammatory polyp and the juvenile polyp. And, just realize that those overlaps exist. Now, most of the juvenile polyps tend to be benign. Rarely you are going to see dysplastic changes, and this was one of those patients that actually had a little bit of low-grade dysplasia in one of multiple polyps that we saw, I think, about last year. So there are three clinical variants of the juvenile polyposis syndrome, the ones in the infancy that tends to present under the age of 2 years, and that tends to have very poor prognosis because the patient just presents with a lot of GI bleeds, diarrhea with a lot of mucoid diarrhea. So some of these patients may end up in places where they do intestinal transplants. You might actually see some of these patients having that very early on. And then you have the JPC that is limited to the colon, juvenile polyposis coli, and then the generalized type. So still on the hematomatous polyposis syndrome, we have the Peutz-Jeghers. So most people call it Peutz-Jeghers. I was raised to call it Post-Jeghers, but it's PJP syndrome. And again, we already talked about the gene that is mutated in the patients with PJP. So this is a case of a 59-year-old man who actually had a history of prostate cancer. And I don't think the prostate cancer had anything to do with his syndrome. He had prostatectomy, he had some radiation, and then he presented with rectal bleeding, after he started anticoagulation. So he had colonoscopy because of his rectal bleeding, and he had multiple polyps. And this is what the polyps look like. So again, we've seen this, and remember one of the highlights of the PJP is the arborizing smooth muscle within the mucosa that gives you this kind, I like to call it a Christmas tree, kind of appearance. Some people think it's more like a mushroom. So anyway, you can pick your own favorite vegetable and then just name it after that. So you see the arborizing smooth muscle, and it's very easy to recognize. This is a very low power diagnosis. Once you see it, it's not that difficult, especially in the colon. So we'll talk about the stomach in a few minutes. Again, this is a higher magnification. And so what you see here, unlike the juvenile polyp that we see, is that you don't see a lot of those dilated crypts in the cases of Peutz-Jeghers syndrome. You can get surface ulceration as well. You might be able to get some granulation tissue because of the ulceration. But I think the highlight of that is that complex, but it's very nice and beautifully laid out structure. Now, in the stomach, again, we covered this earlier in the morning. The changes that you see in the stomach can look very much like what you see in the colon, but it's not always straightforward. So the smooth muscles are not always quite clear. And sometimes you are vacillating whether you are dealing with an hyperplastic gastric polyp or you are dealing, with a Peutz-Jeghers polyp. And most of the time, the history, is really very important. Unfortunately, in both cases, you can get multiple polyps, whether you are dealing with a hyperplastic polyp or you are dealing with Peutz-Jeghers polyps. So when you don't see the arborizing smooth muscle, like you don't see it very well in these sections, just go back and look at the history very well, having in mind that what you call it and the number of polyps might change a lot of things that you might not even be aware of down the line once you made that diagnosis. So this is what it looks like. And some of them can be so complex that they start looking like, again, I think my favorite fruit here would be grapes. So a bunch of grapes. So think about them. But if you take each grape on its own, the surface tends to be smooth. And you might see some evidence of vasculature even right on top of the bunch of grapes. There may or may not be ulceration on the surfaces of some of these polyps. Okay, so again, just to rehash what I just said. When you see those arborizing smooth muscle with irregular normal crypts, not very dilated like you see. Occasionally, of course, they might be dilated, but rarely do you get a lot of dilatation there in these polyps. Epithelial displacement is also quite common. And the commonest, the closest that I can see is the one here. But sometimes you can get this epithelium displaced and you start wondering whether something is right there in the submucosa or not. So how do you diagnose Peutz-Jeghers? So this is one of those polyps that are actually very, very rare outside of a syndromic setting. So when you have 3 or more Peutz-Jeghers polyps, that might just be all you need to get to diagnosing that syndrome. So when you are reviewing multiple site biopsies in the same patient, keep it at the back of your mind. And like Dr. Luquet mentioned this morning, these don't have to be the same polyps in the same colonoscopy. So this might be cumulative number of polyps in the same patient over 1 or 2 years. So these are some of the other criteria that might get you thinking of Peutz-Jeghers syndrome. Any patients with a family history and any number of PJP in that patient might just do it, although this is probably becoming less and less an issue in these patients. But the important thing with some of these syndromes is that their manifestation is just not limited to the gastrointestinal tract. So we saw some nice pictures of patients with mucocutaneous pigmentation this morning in those patients with Peutz-Jeghers syndrome. So again, sometimes for those of us who really want to go deeper into the biology of the phenotype that we deal with every day, it's important to know what are these genes. And I think some of these genes is not unusual for you to come across them in other biologic processes when you are dealing with them. So what's the gene? So the STK11 gene, it's a form of a kinase. So it's one of the serine threonine kinases. And what it does is to maintain self-polarity in a lot of tissues. So when you think of all the organs where polarity is quite important, it begins to make sense why some of the manifestations of this syndrome. So in the GI tract, we depend on the polarity a lot, to define a lot of the processes. The same thing in the skin, you want the pigmented cells to remain in the basal layer. In patients with Peutz-Jeghers syndrome, one of the things that you see in the pigmentation is the loss of that polarity, that you start getting the pigmented cells, not just in the basal layer, but you get some of them now climbing up. So it's sometimes understanding the function of the gene can also help you to understand some of the, manifestations. Now, there is an alternative gene that also is being implicated in patients that do not have the STK11 mutation, which is the MYH11 gene. And a minority of patients might have their Peutz-Jeghers explained on account of that gene. So solitary non-syndromic PJP is quite rare. Okay, I believe it exists, but it's not as common as any of the other polyps that we tend to find. Intussusception is actually one of the commonest presentations, especially in children. And then remember that some of these patients may come with other history of ovarian cyst called stromal tumor with annular tubules, adenoma malignum, or what we used to call minimally deviated adenocarcinoma of the cervix, Sertoli cell syndrome, and of course, breast carcinoma. Seems like almost every syndrome has some form of breast carcinoma risk, as you'll find out. I'm not going to say much about the Cowden syndrome today, but we can't complete the hematomatous polyposis syndromes without talking of the Cowden syndrome. And again, it's mostly PTEN mutation in most of the patients. The thing is that it's not really as uncommon as you might want to think. So patients that, depending on which side of the equation that you are likely to see a lot of patients with Cowden syndrome. And of course, the people that deal with thyroid cancer, especially, they are probably more familiar with the Cowden syndrome that we are. But For us in the GI tract, this is one of the syndromes that you are likely going to see a non-epithelial polyp. So you can get a biopsy in patients that's coming as a screening colonoscopy and they get some bumps and you look at it, there's no epithelial polyp, but then you start seeing this and you start scratching your head about what you might be dealing with. So when you go on hyper, you might be lucky to start seeing some ganglion cells within the benign spindle cell proliferation. So this is S100 here that shows that the spindle cells and the ganglion cells are all positive. And they can be quite small, they can be multiple, they can be diffuse, and sometimes you might be lucky and get a fairly big ganglioneuroma. So this is one of those that you might come across in your practice in patients with Cowden syndrome. So the lifetime risk for colorectal carcinoma in these patients is anything between 9 and 16%. Now, again, this was mentioned earlier on. So, but just know that there's a serrated polyposis syndrome that is non-Lynch. So it has nothing to do with the MSH1 or any of the other genes that we are used to. And this, when you have 5 polyps proximal to the rectum, 5 or more polyps proximal to the rectum, serrated polyps, and it doesn't matter whether this is SSA or whether this is hyperplastic polyps, or any one that is, 2 of them must be more than 1 centimeter, or any other size that is more than 20, as long as 5 of them are proximal to the rectum. So that's having in mind that hyperplastic polyps are really, really very common in the rectum. So that's on its own is not going to count towards the 5. So nobody really knows the exact, inheritance pattern of the serrated polyposis syndrome. We know that a lot of those serrated polyps have either the BRAF or the KRAS mutations, which is again not new compared to other serrated polyps outside of this syndrome. But we know that in these patients, there's a higher risk of finding a cytologic dysplasia in some of these polyps. And again, like I said, hyperplastic polyps is counted as part of the number that you need to make that diagnosis. So there are a few other syndromes that I'm not going to touch on today. But again, last night we were talking about 2 groups of people who, when you talk about signal ring cell carcinoma of the stomach, and we were joking and say, well, there are 2 groups of people, those who have missed it and those who are going to miss signal ring carcinoma. And somebody's added and said, those who have missed it and lied about it. So it's not, and I've seen a few biopsies from the stomach in patients that were not even being questioned, to have familiar, so the last one I saw was a patient with a history of lobular carcinoma and had some other, upper GI symptoms, and then just got biopsy. And there you see all those signet ring cells in the mucosa. So CDH mutation, underlies the familiar gastric carcinoma syndrome. And so you might come across that. And some of those patients are going to be patients that are undergoing screening, and they can do what we call a mapping biopsy. And you just have to be careful that you want to look at multiple levels. One of the other cases that I remember was a patient that was done outside, and there was that small cluster of signet ring cell within the mucosa. And so the patient was referred to us, and so we had to review the biopsy. And there, of course, the signet ring cells were there on the biopsy. And so they decided to do a mapping biopsy right here. So they went there and took from the body, from the incisor, from the antrum. And so we got about 6 or 7, different grouped biopsies. And there was no single signet ring on any one of those biopsies. So it could be really, really very patchy. And it was so suspicious because the endoscopists didn't know what to do with that patient anymore. So he asked us to call for the original biopsies to be sure that those were not mixed up. So we had to call back those cases, and we actually went ahead and did genetic testing on them just to be sure that the single cluster of signet rings actually belonged to that patient, and it did. So familial gastric carcinoma, is something that we are going to see. Gaps, I'm not going to say much, so I want to move on to some of the new kids on the block. And these are the autosomal dominant groups, and they all cause real epithelial polyps. And so there are three big genes here. So the first one is actually, there's a fourth one. So the fourth one, I'll talk about it in a second, but that is not as new, as these other three that we're talking about. So the POL-D and POL-E, which are the polymerase proofreading associated polyposis syndrome. So POL-D is D1 and E is epson. Or the G. And then the other one is the NTHLA-L1 associated syndrome, and then the MSH3. So we all know about MSH1 and MSH6 in the Lynch syndrome. So this is another mismatch repair gene, but with a slightly different function. So let's look at the polymerase proofreading associated polyposis. So the epsilon and the delta genes are the two genes that have already been implicated as causing the germline mutation that underlie risk for colonic carcinoma. So these have to be germline, number one, and it has to be homozygous germline. So that is what differentiates this from the autosomal dominant inheritance of the Lynch syndrome, of the FAP, and all the other genes that we've talking about. So most of the other syndromes, the germline mutation is just a single allele, and the particular cell that transforms subsequently undergoes mutation in the single one. So that's the autosomal dominant inheritance. So because the penetrance in those cases is quite variable, but these are cases where the patient is born with homozygous mutation in the two alleles. So these are patients that, so the function of the gene, so they code for proteins that are responsible for DNA polymerase. So polymerase, we remember, is quite important in DNA synthesis. So that is what determines, when a gene is coded or not coded. They also have exonuclease functions. So what that means is that they are responsible for promoting the DNA synthesis, but also responsible for repairing the damages that result during the DNA synthesis. So they have those dual function. So they enable them to, their function enable them to repair damages right there and then. So whenever there's mutation, there's loss of function. And so all those cells become microsatellite. Okay, so I'll come back to the microsatellite. So they are microsatellite stable, but they are genetically unstable. So what that means is that every cell that replicates, there's always a chance of some genetic misreading. So in the MSH1 and MSH6 and all the usual Lynch syndrome, they tend to repair microsatellite abnormalities. So these are areas where you get trinucleotide repeats or binucleotide repeats. So, but these particular genes, they are not, specifically for the trinucleotide mispairing. So when they are mutated, the trinucleotide, which is what determines the microsatellite stability or not stability, is not really where the problem is. This is in other forms of DNA, metabolism or mechanism in general. So they are stable. So when you do your MSI testing, you are going to not find them to be there, but it's still a form of mismatch repair. And so what they call is, this is a kind of oligoadenomatous polyposis. And what it means is that just one gene misreading is going to be sufficient, to cause the phenotype. Unlike in the other cases of where you have the microsatellite instability, that you really have a major misreading of the satellites. The other tumors, endometrium, and of course, breast cancer. So if somebody asks you about some of these genes and say, what are the tumors there? If you start with the breast cancer, you are almost always going to be right in them. But one of the things that you see about the cancers that are involved in these genetic diseases, and you're going to see as I go, these are the surfaces where by nature, there's a continual renewal of epithelial cells. So you talk of endometrium, you talk about the breast, you talk about the colon or the GI tract. So the more replicative a surface is, the more likely it is that there's going to be a genetic accident in those days. So in patients that have the polymerase proofreading associated polyposis, they tend to have anything between 200 and 100 adenomas, usually in the colon. And I think the average is about 50 in these patients. Okay. And then, they meet the Amsterdam criteria, so which has to do with family history and the age at which they are presenting and other tumors that they may have. So once these patients are picked up, screening program is going to start usually around the age of 20. So these are patients that in the adult setting, you might be getting series of biopsies upon them as a result of that. And they need to undergo colonoscopy every 2 years and also upper endoscopy every 3 years. Looks like there's a cohort of them that also has brain tumor, especially gliomas. And then, of course, there is a screening program for endometrial carcinoma in the patients that have that. So this is their specialty. So there's a high proportion of GC to TA transversions in the patients that have the, especially the pole E. Okay. So instead of having a sequence of GC, it tends to change to TA. And so that's usually where the point mutation is. And then depending on the particular process that you are dealing with, it might lead to missense mutation in the gene or in the enzyme, especially the exonuclease. So the exonuclease part of the gene, so don't forget they have both polymerase and they also have exonuclease function. So it's the loss of exonuclease function that is actually more important in the development of these tumors. Okay. So yeah, this is also important. So some of them can also have a permutation, meaning that the transversion is not just in one point within the gene, that this can occur several times within the same gene. So they say they are hypermutated. And then because of that, they accumulate other mutations within the same tumor. So by the time you are looking at a colorectal tumor in those patients, you see a lot of mutations. And some of those mutations can now secondarily be in the MSI gene. Okay, so there are some of those ones that are reported. So when you test for your MLH1 or you do your immunohistochemistry, in some of these patients, you may start seeing loss of the MMR genes that we test for. And this will not be Lynch syndrome truly. This might just be hypermutated Polyps syndromes. And those tumors tend to be very high grade. And so as far as last week, when I was finishing this talk, I actually didn't see a single case of somatic Polyps mutation, that's been reported. But one of the reviews that I read said that it's been reported. I couldn't find it, but if it exists, it must be, quite rare. Okay. Now, I said that there were 4. That is just that one of them is not quite new. So the YH-associated Polyposis coli, it's actually in the same domain as the POLD and the NTHL1, gene. Because again, they perform similar functions. And this is another one of those autosomal recessive inheritance that you are going to come across. So the MTYH and the NTL genes, they both are similar genes, they perform similar functions. And what they do is that they correct mutations in the DNA that affect uracil during the CNS synthesis. So all the errors that affect deamination of cytosine to uracil are usually corrected by this by these two genes. So now UDG is usually very crucial when you talk about UDG glycosylase is usually very crucial when you talk about DNA repair. So when you lose these genes, and again, it has to be biallelic loss of these genes, errors, it becomes very easy for errors to accumulate, and that will be the basis for the autosomal recessive pattern of those genes. So that's the other one, the NTH1, they are identical genes. And I believe that in the months to come, we're going to be hearing more and more about the NTHL1. Now, this is not something that we are required to test for or to know that they exist. But especially when you are dealing with a patient that looks like it's FAP, but doesn't have the required number of polyps and may not be FAP, you might be dealing with a patient with MUT-YH or NTHL1. And some of these patients, they will have family history. So it may come up in discussion with your endoscopist to ask you, what do you think is going on? And so it will always be an opportunity for you to suggest to them that maybe they want to screen for some of these other genes. And then the fourth one in the group is the MSH3-Polyposis Syndrome. Again, this is autosomal recessive, unlike Lynch syndrome. And so this is probably one of those mutations that could explain non-Lynch, non-MLH1 sporadic, but MSI unstable tumors. So this is one of those microsatellite repair, different from the 4 genes that we look for in Lynch. So this has a unique dysfunction, of the DNA in the protein that is coded by the MSH3 gene. And the patients that have a germline mutation in this gene, they tend to develop a lot of aneuploidy, and they tend to develop a tumor that looks very high grade. The incidence of some of these tumors, I don't think is really well known, because we're just beginning to understand and appreciate some of these tumors. I think the first publication on this that I saw was, I think, in 2015 or 2014. So there's still a whole lot of things that are not known about this. But when you look at the immunohistochemistry, so when we stain for the MMR proteins, MSH1, MSH2, and all the other proteins, because they are autosomal dominant, we have a colon as our internal control. So the normal colon that still has one of the allele is going to be staining for the MSH1 or whatever it is only going to be lost in the tumor. So if you ever have the immunohistochemistry for MSH3 and you start staining them, find that both the normal colon and the tumor will be missing the protein, because again, this is a germline biallelic mutation in these patients. So as in the coming days, we're going to be hearing more and more of some of these, okay? And this is the way I tend to remember them. So the first group is the expansion of the colorectal polyposis syndrome, the adenomas. And so in addition to the FAP, and then, we talked about the Gardner syndrome and the Torre and all those other attenuated forms. These are the other groups that are going to be joining those ones. So these patients also tend to have adenomatous polyps throughout the colon. And the second group, so again, they have those adenomatous signatures. And the other group are the amatomas, the amatomatous polyposis syndrome. And we covered some of them just now. So, and then we have the Lynch syndrome, which again, we are all familiar with. But then we also have some of those other syndromes that are not Lynch, but they present with the serrated lesions. So BRAF and the KRAF are usually mutated in these serrated polyposis syndromes, but they are not Lynch. Okay. So this is just to remind us that as pathologists, every time that we release a diagnosis, sometimes inadvertently we are confirming the existence of a syndrome. Some of those syndromes, as you see, they don't require a lot of polyps, to get to that point. So it would be very nice for us to know what. And I've had endoscopy calling me after, signing out a juvenile polyp, asking me if I think this patient has a juvenile polyposis syndrome, because I wasn't aware that that patient had juvenile polyps, removed in the past. So it's always good to know. It's good for us to know the genetic basis and some of these genes. And I think some of them eventually, if not right now, eventually some of them are going to have immunohistochemistry that we will be required to test for. So I just showed you an example of MSH3. It's not required today that we stand for MSH3, but I think eventually, we'll like to start talking about them. So I'm going to stop here and take any questions. Thank you.